Good afternoon. I'm Christine Saw. Welcome to this news briefing from the 250th National Meeting and Exposition of the American Chemical Society in Boston. We're joined today by Dr. Peter Caravan from Massachusetts General Hospital. He's going to talk to us about a new method for detecting blood clots in the body. Dr. Caravan.
Blood clots are associated with the leading causes of death and morbidity, for instance, heart attack, stroke, pulmonary embolism, deep vein thrombosis. These all occur because of blood clots in the coronary arteries of the heart, or in the brain, or a clot in the lungs, or a clot in the legs. There's an urgent need to find these clots when they occur. In my lab, we've invented a new molecular probe that, upon injection into a vein, will travel through the body and find blood clots wherever they're occurring, be that in the venous system, in the arteries, in the chambers of the heart, or in the lungs. So why is that important? To give you one example would be in the case of stroke, where if you've had a stroke, the leading risk of having a stroke is prior stroke. And it's very important to prevent a secondary stroke. Stroke is an incredible burden to the patients that have stroke and cost to society. For instance, about over $70 billion in the United States alone in hospitalization costs, and over $35 billion a year in lost in effect to the economy because of lost work time. So stroke prevention is really key. Once you've had a stroke, it's crucial for the clinician to find the source of the clot that causes stroke. So in a stroke, you have a blood clot that forms somewhere, maybe in the heart, maybe in the carotid arteries, and then it breaks off and travels to the brain and causes a stroke. What's key then is there still clot remaining at that source site, and can we find it? And because this will have a strong impact on how those patients are treated. If the clot is remaining, the patients will be treated more aggressively. If there's no clot remaining, then the treatment will be accordingly. And so there's a real risk here, because if we treat patients too aggressively, there's a risk of bleeding, which we don't want, but we also want to prevent their stroke. So finding these clots is paramount. And currently, we have ways to do this in radiology, but they involve multiple tests in multiple body regions. What we believe is that our technique with a single injection in a whole body scan can find clots wherever they are. And so that's the technology, and I'm happy to talk about it further.
Thank you. Do we have any questions?
So it's Kath O'Driscoll from Chemistry and Industry magazine. I understand that the test you developed relies on a fibrin probe. When did you first, what year did you actually discover that fibrin reacts with these?
So an early prototype of this compound was reported in 2011 in Journal Radiology. And then in the subsequent years, with great support from the National Heart, Lung, and Blood Institute at the NIH, we built on that prototype and optimized it to a point where now we're ready to go forward into human studies.
Do you have any more details of that, when you can go into human studies, where you might do that work?
We're planning to do that work at Massachusetts General Hospital here in Boston. We're planning to start later this year or in the beginning of next year.
Clarify what this probe will mean for patients in terms of, will it be more convenient for them? Is it a faster process? And also, what does it mean in terms of hospital costs?
Right, so those are all great questions. It's a very convenient test in that it just involves a puncture of a vein to deliver the probe, and because it's a single scan, which can encompass the whole body if the clinician desires, it can replace multiple tests, and that's where we believe that there's real value. Instead of needing, for instance, in this example of stroke follow-up that I gave, one might need to have an ultrasound of the neck, might need to have an MRI or a transesophageal ultrasound of the cardiac chambers, and maybe another compression ultrasound of the deep veins of the legs. And this would be one test that could replace all four of those tests. It's a rather expensive test. This is a technique called positron emission tomography. So it's not a cheap test, but but the cost of the test is appropriate to the clinical decision that's occurring, because if you can prevent a stroke, then you're going to save the healthcare system a tremendous amount of money.
And what about accuracy and sensitivity compared with the other tests?
Right, and that's exactly what we aim to study when we transition this probe into clinical studies. All our data in animal models is very good. We have very high accuracy. We just had a paper come out online yesterday in the journal Atherosclerosis, Thrombosis, and Vascular Biology that showed in a blinded review of blood clots in arteries and veins in a rodent model that the accuracy was about 97%.
You mentioned in your summary that, the example of somebody who's had a stroke and, preventing further strokes or finding the clot. Is that the patients that you're targeting with this, or would there be sort of high-risk patients that haven't had a stroke yet, and it would be like an exploratory kind of probe?
Right, that would be another application would be in a case which we call a transient ischemic attack, which is a stroke-like symptom that you would have where you'd have some sort of neurological deficit that clears, and where you would have suspicion that this was sort of a mini stroke, if you will. Again, those people are at very high risk for having another stroke. So that this is the neurologists at our institution are very excited about this technology for those reasons.
Any other questions? Yes.
Bill Buslig, ACS News Service. I may have missed this, but what is the isotope that you're using for the label? How long after the injection that you can actually, are you following the injection and see where it stops? Or, and most important, what's the clearance of the isotope out of the body? Because you don't want to leave it there.
Right, so the isotope that we're using is copper-64, and it has a half-life of 12.7 hours. So even what remains in the body will eventually decay away. And the dose that we provide, the total mass dose is less than 100 micrograms per human subject. So it's a very low dose overall. In terms of the clearance is very fast. It clears through the kidneys, and we would probably administer it to the patient, wait an hour or two, and then have them come into the scan room and get a scan.
Once the fibrin gets labeled, obviously it hopefully isn't mobile. What can you do? Are you going to go ahead and try to dissolve it with some enzymes, or operate perhaps if the clot is large enough?
Right. So that depends on the specific location of the clot and the type of pathology. But there are different strategies that are taken. So one is one can go in with a catheter and pull the clot out to perform a thrombectomy. Another approach is to infuse an enzyme called tissue plasminogen activator, which will dissolve the clot. We've previously shown that we can actually image the dissolution of clots in animals. Another approach would just be to prescribe some sort of antithrombotic to prevent further clot formation and allow the body's natural lytic system to dissolve the clot. And those are based on the location and the clinical symptoms that the.
Thank you very much.
I was wondering actually if you could just talk a little bit about the slide that we have up here.
Oh, sure. So this was an example where we were trying to demonstrate how one could detect blood clots in a single whole body scan. So we're using a technique here combining positron emission tomography, PET, with magnetic resonance imaging, MRI, in the same device. So these are clinical. This is a clinical scanner. This is an image of a rat. It's a coronal image, so you're looking straight as you're looking at me, okay? And I wonder, there's not a pointer here, but maybe I can I go over here?
Go ahead.
So these are these bright.
Into the microphone, that would be great. Thank you.
Sure thing. So, so the grayscale image is an MRI of the rat. So these are the shoulders here, the arms. This is the head. This is the liver, and the white here. These are the carotid arteries that come up. And so this slice through the rat, what we're seeing is some focal hotspot right here in the carotid artery, and this corresponds to a clot that we can determine histologically as a blood clot. And so this would be the idea that we could take one single scan and localize the position of the clot in the animal. In this study, there was another blood clot in the femoral vein of the leg, but that's on a different slice through the animal. So we could find that as well. And so there's the other thing that was very striking about this image is most blood clots that clinicians care about are in the chest and in the head and the neck. And what you see is very little background signal here, so we have very high conspicuity, and that's another reason why we're very excited about this.
And can you tell the size of the clots as well from the imaging?
Yes, so we can see the extent at the resolution of these cameras, which is down to, for a clinical camera, it's about 5 millimeters, so it's quite reasonable to pick these things up and to look at their extent. And we've also shown that the uptake of these fibrin-seeking probes depends, as you might expect, on the amount of fibrin that's in the clot. And what's important is that newer, fresher clots have more fibrin than older clots. So we even have, we think, a way of identifying the newer culprit lesions versus, say, something that's more stable.
Great. Do we have any other questions? Yes.
There's an online question from Vijay Venkantraman. I don't know what his or her affiliation is, but they want to know the name of the journal where the study was published recently.
All right. The journal is let me start again. Atherosclerosis, Thrombosis, and Vascular Biology, which is usually abbreviated ATVB for that reason. Yeah.
Makes sense. I think we have a question in the front.
Hi, Jonathan Webb from BBC News. Just a couple of questions. First of all, you were describing this image, and you say the grayscale is an
MRI.
MRI. So the hot colours are the PET scan?
Yes, that's right.
Okay. But diagnostically, you would just be doing the PET scan?
No, today all PET scanners are part of a hybrid device with either a CT scanner, a CAT scanner, or an MRI.
So you would get an image like that of a patient.
That's right, and that's another great point, because the anatomical scan from either the CT scan or the MRI scan will provide a great anatomical context. So, for instance, here, just seeing that spot sort of around the neck. But with the MR image, we can tell that precisely that it's localized to the carotid artery, and precisely where in the carotid artery as well.
One more then. Just curious about how big a deal this is compared to current diagnosis. I mean, you mentioned that you might first have an ultrasound and then have something else. If everyone can go straight for this diagnostic straight away, are we looking at saving a certain number of lives, or does it just speed things up? What's the what's the gain? Right,
that's a good question. I mean, that sort of gets to a little bit about healthcare economics. So different tests. So something like ultrasound to look for blood clots is a much more cheaper test. And that's a test that can be performed in a GP's office. This would be a much more specialized test at a tertiary care center. And so typically, a test like this, you need to have a decision point which is really going to impact patient treatment in a meaningful way. And in this case, in the example I gave with stroke, I think that would be a good example where if the test is negative, you would treat the patient very differently than if the test was positive. And no treatment would cause great risk to the patient.
Do we have any other questions?
Katie Cottingham, ACS News Service. So I was wondering, what will you do next? Is it the clinical trials of this probe, or are you going to develop new probes for other conditions?
Right. So we're doing both. Currently we're compiling the regulatory documents that will allow us to use this probe in patients, and we're hoping to do that, as I mentioned, later this year. At the same time, in my lab, we're developing additional probes. There was another talk this morning by Dr. Pauline Dessager looking at detection and quantification of pulmonary fibrosis using a different mechanism, targeting excess type 1 collagen in the lungs. So we have different approaches. This is the focus of my research, is molecular probes for diagnosis. Thank you.
Any other questions? All right, I think that wraps it up then. Thank you so much. Thank you, Dr. Caravan. The archived version of this session will be posted at bit.ly/ACS Live Boston. Please join us for our next press conference tomorrow at 9 a.m. to hear about new technology that will bring us more sustainable, less expensive white LEDs. Thank you.